Hello everyone. Assalamu alaikum. My name is Salsabil and I'm a fourth year medical student. This time my PAL is about the pharmacology practice questions in ENDREP Pro. So how this session is going to go is that we will kind of practice a lot of questions. Try to keep tally of your score, try to practice. If you haven't finished all the pharmacology lectures, try to finish them beforehand and then try to attend the questions as I go through the questions and try to keep a tally of your score. And yeah, that's it. Good luck with your exam. I know it's very crammed, so I tried to keep my session as concise and as limited as possible. Inshallah, we'll be done within an hour. If not less, I guess. Yeah. All right. And here is my email and my phone number. If you guys have any questions, please feel free to reach out to me. And yep, let's get started. Okay, straight to your question. All right, 45-year-old woman presents to her doctor with feelings of fatigue, increased appetite, increased sweating, and palpitations. Her doctor also notes that her eyes appear unusual, as you can see in the image. She receives pharmacologic treatment for her condition, but soon develops a fever and multiple infections in her throat and GIT. Her doctor quickly discontinues the medication. Which medication was she most likely prescribed? So I'll give you a minute. This is a recorded session, so I'm just going to say the answers, and when you're watching the video, you can just pause along and take the time that you need. So here, the answer is going to be D, hypothyroidism. First of all, what is the diagnosis here? The diagnosis is Graves' disease. How can we know this? There are signs of hyperthyroidism, right? So there is increased appetite, increased sweating, basically everything about the metabolism is increased, right? So there is increased appetite, increased sweating, fatigue, palpitations. Her eyes appear unusual. What is this sign called? It's called exophthalmos. And you can see lid retraction, exophthalmos. You can also see periorbital edema, not really visible in this patient, but it is visible in, it is usually seen in Graves' disease. So these are the signs and symptoms of Graves' disease. Then she starts taking a medication that gives her multiple infections and fever in her throat and GIT, basically in different places. So this means that this medication is causing something which increases her risk of developing infections. And this is caused by propylthiouracil, and the side effect of propylthiouracil that they're referring to here is called agranulocytosis. I hope you answered all of that. I wouldn't know. Okay. So here, what is the diagnosis? As you said, as I said, Graves' disease. And what are other options are available? Other options can be, you know, carbimazole, methimazole. We also give radioactive thyroid or iodine 131. Sorry, not thyroid, radioactive iodine 131. We also give other options such as Lugol's iodine. It's not really used much, but even the pathophysiology is not that clear. But here we use propylthiouracil. The mechanism of action. Try to guess. Tell me the mechanism of action. I won't be able to hear you, but I know that you're answering. Okay, so it causes, actually, I'm not going to say it because maybe one of the next questions is about it. Okay. So here, from the slides. For most of these questions, I brought pictures from the slides so that you can directly correlate instead of using, what do you call it, external resources. So here we refer to agranulocytosis, usually occurs within 2 to 3 months of treatment. So you really have to keep, and this is a serious side effect, okay? Okay, it's also teratogenic, so it's more serious with methimazole and carbimazole than propylthiouracil, which is why in the first trimester you use propylthiouracil and then you continue with methimazole or carbimazole, if I'm not wrong. Okay, next question. 22-year-old woman comes to the office due to palpitations, weight loss, insomnia. She lost 7 kilograms in the past 3 months, no other medical problems, takes no medication. She does not use tobacco, alcohol, or illicit drugs. Blood pressure is 130/80, and pulse is a 104 and regular. Thyroid gland is diffusely enlarged and non-tender on palpation. Lab studies show markedly decreased TSH and elevated thyroxine. Methimazole monotherapy is initiated. 2 months later, her symptoms have resolved. The treatment most likely improved this patient's condition by directly inhibiting which of the following processes? Okay, you can pause the video now, think about it. The answer is going to be coupling of iodotyrosinase. Okay, so this is the mechanism of action of methimazole and also propylthiouracil because they both inhibit thyroid peroxidase. They're both thyroid peroxidase inhibitors. Propylthiouracil has an added effect of also decreasing the peripheral conversion of T4 to T3 and thus decreasing T3 levels. Okay, here as you can see, they have decreased TSH and increased thyroxine levels, which is very, a diagnostic of primary hyperthyroidism. Okay, if TSH was increased, it would be secondary hyperthyroidism, which can be caused by pituitary adenoma and all of that. Okay, so this is the production process, or what do you call it, the thyroid hormone synthesis, and they inhibit peripheral conversion of T4 to T3. This is mainly propylthiouracil, but thyroid peroxidase is inhibited by both propylthiouracil and methimazole, and its what do you call it, mechanism of action is through blockage of iodination and coupling. Okay, all right, I hope that's clear. Next question. So a 55-year-old man comes to the emergency department due to progressive weakness and lethargy. Over the past 3 months, he has had excessive thirst, frequent urination, unintentional 5 kg weight loss. The patient has not seen a physician in several years. His parents have type 2 diabetes, blood pressure is 1/8/60, pulse is normal, BMI is 38, so he's obese. Physical examination shows dry mucous membranes, poor skin turgor, so he is, what do you call it, dehydrated. Lab testing shows blood glucose concentration of 600, which is very, very markedly elevated. Serum beta hydroxybutyrate is normal, so it's not he's not ketotic, or he's not under ketoacidosis, and his hemoglobin A1C is 14, which is very, very high. Normal is 6.5 or lower, and diabetic is, I think, 7. So A1C 14 is double that, which is very high. The patient is admitted for IV fluids and insulin infusion. The next day, his symptoms and blood glucose significantly improve. In preparation for discharge, the insulin infusion is changed to a subcutaneous regimen that mimics the physiological pattern of insulin release. So all of this very elaborate scenario just to ask, the patient's insulin therapy was most likely transitioned to which of the following regimens? Okay, I'll give you a minute, or you can pause the video now. The answer is going to be D, which is insulin glargine once daily plus insulin lispro before each meal. So basically what this question wants you to know is the physiological release of insulin and its schedule, basically, right? So what do we have in our body? What does our physiology normally do? We normally have a physiological basal levels of insulin, which is maintained throughout the day. And we have boluses of insulin that are released after each meal, right? So to mimic that, we would need something that produces basal insulin, in other words, a long-acting insulin, which is glargine. And we need something that gives us insulin after we have meals, right? Which is insulin lispro. And this is a rapid-acting insulin. All right, so let's talk a bit about the insulins. I highly, highly recommend this video. I cannot tell you how many times I watched it. It's by Dirty Medicine, and it's about injectable anti-diabetic drugs. Actually, it has both oral and injectable. And I highly recommend the mnemonics that he talked about here. So, what do you call? Yeah, so this is the summary slide that I got here. So rapid-acting insulins do not lag. So LAG, lag. Lispro, aspart, and glulicine. Okay, they take 1 to 1.5 hours to peak. So you eat it, you take it just before, what do you call it? You inject it just before you eat a meal, and it peaks within 1 to 2 hours of eating the meal, right? And it only lasts 3 to 4 hours. Then you have short-acting insulin, which is regular, and this peaks in 2.5 hours. Then you have intermediate acting insulin, which is NPH. Okay, here you can use these mnemonics. I personally just use the lag because that's what sticks to me, but you can use the other ones as well. And you can use the long-acting ones. So long-acting ones are glargine and detamar. So now, like me, you might also be confused about glargine and glulicine. Glargine, think large. Large means long-acting, whereas glulicine, not large, so that's rapid-acting. Okay, because both of them start with G, and I was confused with that. So long-acting, it's just like the physiological basal levels of insulin. It has no peaks, and it lasts approximately 24 hours. Also, yeah, so these are the types of insulin. Okay. Okay. Now, this is a diagram from first aid. I highly recommend going through this graph and being able to recognize it in an exam question. I don't know if we got it exactly, but I have seen these questions in board exams or what do you call it? Normal university exams. So as you can see, this has the highest peak and the shortest duration. Then you have regular insulin, then you have NPH, which is intermediate acting insulin. Then you have detamir and glargine. You can see glargine has a slightly higher kind of half-life or duration of acting compared to detamir. Okay, all right, moving on. So 32-year-old woman recently diagnosed with Graves' disease and was started on methimazole 8 days ago. Okay, she presents to clinic reporting ongoing symptoms of palpitation, sweating, irritability, just hyperthyroid symptoms, right? She's concerned that her medication is not working, vitals are normal, and her physical exam is unchanged from initial visit. What is what is the most appropriate next step? Increase dose, start propranolol, reassure the patient, order repeat thyroid function tests. Here you would, the answer is to reassure the patient. And this is something directly taken from your slides. It's, as you can see here, thianamides, they cause gradual reduction in signs and symptoms of thyrotoxicosis about 3 to 4 weeks, right? So it takes a while for the medication to start showing resolution of symptoms, right? So, and she only started taking it 8 days ago. So you would reassure the patient, tell them to continue taking the medication and that eventually their symptoms will subside. And their vitals are normal, so you don't really have to start propranolol for symptomatic relief. Propranolol is a beta blocker, so you use it if there is, excessive tachycardia and all of that. But since we already started the medication, I think we'll wait until the effects of medication show. Okay. Yeah, order repeat thyroid function test, no need. We know that it takes a while to act. Increase dosage, no need. And start propranolol, no need. Symptomatic relief, her vitals are normal. Okay. All right, so next question. All of the following are goals of hypothyroidism therapy, except which of them? So pause the video if you need some time to think. The answer is D, reverse mental retardation in patients with cretinism. I mainly wanted to include this question. This is just something that I wrote to kind of stick it to you guys' head what the goals of hypothyroidism therapy are. So the goals of hypothyroidism are to cause subsidement of the symptoms, right? To subside the symptoms. So that would be increase in heart rate, normalization of TSH values. So not only the symptoms, but also the clinical levels of TSH, right? And reduction of size of goiter and Hashimoto's thyroiditis. However, you cannot reverse mental retardation that happens in patients with cretinism. Cretinism is what happens in patients with iodine deficiency when, what do you call it, in utero, right? Iodine deficiency, which causes mental retardation in patients. And once this happens, it is irreversible. Therefore, you cannot use hypothyroidism therapy to reverse this. However, for the other ones, as I brought the screenshot again, so it causes symptomatic relief. Obviously, it causes normalization of TSH secretion, and it causes reduction of size of goiter. Okay, but if you use too much of levothyroxine supplementation, it might cause iatrogenic, thyrotoxicosis. So if you have a question, for example, that says a patient comes in with hypothyroidism, you start them on therapy, however, they start getting palpitations, blah, 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 and all of this, think thyrotoxicosis. Or if someone comes in and they want to lose weight, okay? So they want to lose weight, they're undergoing, they read about this new drug that's, that increases your metabolism, boosts your metabolism and whatnot, but they start developing palpitations and rapid weight loss, and all of that. Think, again, exogenous thyrotoxicosis due to over therapy with levothyroxine. So levothyroxine can be used or can be abused in patients who want to lose weight, so you have to keep track of that, and also iatrogenic when you're providing therapy for hypothyroidism. Next question. A 45-year-old man with acromegaly is started on pegvisomant therapy. He returns for follow-up and you review his treatment plan. Which of the following is the most appropriate ongoing monitoring strategy for this patient? Okay, So you measure serum growth hormone levels every 6 months to assess response to therapy, monitor liver function tests, obtain annual pituitary MRI, repeat oral glucose tolerance test, monitor serum calcium and PTH levels, and no regular imaging is needed. Okay, so the answer here is going to be B. So pegvisomant is a, what do you call it? It's a growth hormone receptor antagonist, and it reduces the levels of IGF-1 in your body by negative feedback, right? Because growth hormone causes increase in IGF-1, so, you know, growth hormone receptor antagonist, so it will cause decrease in IGF-1. Okay, so this might cause accelerated adenoma growth, which is why you will have to check the patient through annual MRI scans. Okay, and it can also cause impairment of liver function, so you have to keep check of the liver function tests of the patient as well. So that's why the answer is liver function test and obtain annual pituitary MRI. Okay, then next question. 35-year-old woman presents with a 3-month history of amenorrhea, galactorrhea, and fatigue. Lab workup shows a serum prolactin level of 220, which is very high, and an MRI shows 7 millimeters pituitary microadenoma. Okay, the endocrinologist plans to initiate dopamine agonist therapy. Which of the following clinical findings would be a contraindication to initiating first-line pharmacological therapy in this patient? So these are a bunch of values. Okay, so blood pressure 164/104, which is very high. ALT, what do you call it? Normal ALT. Hemoglobin 8.1, which is again high. TSH, low TSH, and normal heart rate. Which of the following would be a contraindication to indicate initiating first-line pharmacological therapy? This would be A, right? So this is because bromocriptine, which is a dopamine receptor antagonist, it is used for what do you call? It is contraindicated in cases of uncontrolled hypertension. Okay, so this is an absolute contraindication. You cannot give it to patients who have uncontrolled hypertension. Just a review of other adverse effects, it can cause nausea and vomiting, it can cause headache, dizziness, constipation, and also worsening of psychotic symptoms because it influences the dopamine levels, right? All right, so these are the side effects of bromocriptine. Again, nausea, vomiting, headaches, what do you call it? Worsening of, psychotic symptoms and constipation, and it's contraindicated in uncontrolled hypertension. Okay, so 62-year-old woman with type 2 diabetes presents to the emergency department with fatigue, nausea, abdominal discomfort, and rapid breathing. She reports that she recently started a new diabetes medication after her A1C came back at 8.4%. Her past medical history includes hypertension, stage 3 chronic kidney disease. On exam, she appears mildly dehydrated and tachypneic. Labs show, you see the pH. Which of the following medications is most likely responsible for her current condition? Her pH is 7.29. Bicarbonate is 18, anion gap is 12, and lactate is 5.6. You will be given the normal values in the exam. So I'll just, I'll interpret the values as well. So 7.29 is acidic. Anion gap of 18 is also very high. Anything more than 12 is high. And pH of anything less than 7.35 to 45, sorry, 25 to 35 is, wait, hold up. Just assume that this pH is acidic, okay? I think it's 7.25 to 35, that's normal. Okay. All right, which of the following medications is most likely responsible? Again, pause the video if you need more time to think, but the answer is metformin. Okay, first of all, okay, tell me, what class of drug is metformin? Metformin is a biguanide, right? What is the main mechanism of action? It increases hepatic gluconeogenesis, right? Okay. Then what is the side effect that we're talking about here? It is metabolic acidosis or lactic acidosis. And you remember this by, metformin, metabolic acidosis. Again, if you watch the Dirty Medicine video, I highly recommend. It's a bit long, but watching it once really like drills into your head all the side effects and all the drugs. Okay, So, just random question. Empagliflozin, which class of drug is this? This is, I believe, SGLT2 inhibitors. I believe, yes. And it causes urinary tract infection. You can remember this with flows into the urine, again from the video. Flows into the urine means basically, it causes more urinary tract infections. Then you have pioglitazone. This is a what is it called? Thiazolidinediones. I can't really pronounce it. Mechanism of action, it it inhibits PPAR receptors. Okay, so, and all of the drugs have the phrase or like the letters glita in them. So you can remember it with bring glita to the party. So glita and PPAR receptors or party, okay? And yep, all right. So again, metformin, it is the first line of medication for type 2 diabetes, as said in this case. So he just got diagnosed with diabetes, and he started with this medication. Most of the times that will be metformin. Okay. It causes no hypoglycemia, which is very good. So it it prevents hypoglycemic attacks. It causes GI upset, again, metabolic acidosis, anything to do with the GI, lactic acidosis, metabolic acidosis, especially in renal dysfunction. And if you remember in this case, the patient has stage 3 chronic kidney disease. So her AGFR is low, EGFR is low, which is why she is more susceptible to developing lactic acidosis. So keep these clues in mind. Okay, next question. A 59-year-old man with type 2 diabetes presents for medication adjustment. His HbA1c is 8.5% despite lifestyle changes. And he has a history of NYHA class 3 congestive heart failure, hypertension, underwent transurethral resection of a bladder tumor 2 years ago. His creatinine and liver function tests are within normal limits. Team is considering initiating an oral hypoglycemic agent. Okay, which of the following medications is contraindicated in this patient? Again, pause the video if you need some time, but the answer is pioglitazone. Pioglitazone, as I said, it's a thiazolidinedione, whatever. It inhibits PPAR receptors, and basically, it is contraindicated in bladder cancer, and especially pioglitazone itself is contraindicated in bladder cancer. Okay, so these are the adverse effects. Remember, pioglitazone, bladder cancer, BP, okay? And then it causes us fluid retention and fluid reabsorption in the distal nephron. So you can imagine someone with congestive heart failure, they already are storing a lot of fluid in their body, especially in their third space, like their third spacing, a lot of fluid in their body. So if you give a drug that causes more fluid retention, that's not going to be good for the patient, right? Again, it causes bladder cancer, causes fluid retention, so not good in heart failure patients, causes weight gain, hepatotoxicity, and osteopenia. So again, osteopenia, rosiglitazone, bladder cancer, pioglitazone. Okay. All right, again, so next question. When prescribing repaglinide, medication history should be carefully reviewed for which of the following drugs? Take a minute to think. The answer is gemfibrozole. Okay, this is just something that you have to remember. There's really no way around it. But this is one of the drugs that that gets affected by other drugs that inhibit or, what's the other word of it? Or induce CYP3A4 enzymes in the liver, right? So any drug that inhibits CYP4, such as fluconazole, erythromycin, prolong the duration of effect, right? And anything that induces CYP3A4, such as barbiturates, carbamazepines, and rifampicin, decrease the effect of meglitinides. And this is just something that you have to kind of remember. The lipid drug gemfibrozole may increase the effect of repaglinide. Okay, and that's why you don't use the drugs together. So again, repaglinide and gemfibrozole. Okay. So don't think about it. Okay. Just pretend you didn't see. Okay. 64-year-old man comes with type 2 diabetes, is brought to the emergency department after being found confused and diaphoretic in the morning. His home medications include metformin, insulin, and pH 30 units at bedtime. His blood glucose on arrival is 42 milligrams. Which of the following best explains his hypoglycemic episode? Right, so 42 is very low for blood glucose. He took metformin, insulin, and pH. Okay. So did he have excess metformin dose, missed dinner, incorrect morning technique, long-acting insulin, and early morning cortisol surge? Take a minute to think, pause if you need to, but the answer is B, which is missed dinner the previous night. Okay, let's go through it. So first of all, excess metformin dose. As we just went through it, excess metformin dose does not cause hypoglycemia, right? We went through it here. Yeah, so it does not have any hypoglycemic effects. So that is not one of the answers. Then missed dinner the previous night. This is the correct answer because he takes 30 units of NPH at bedtime. And as we know, NPH is an intermediate acting insulin, and it peaks like 4 to 6 hours after the patient takes it, right? So if he took the insulin at bedtime and he took it and he fell asleep, he didn't have any dinner, after the insulin peaks, his blood glucose is going to get dangerously low, which is what caused his hypoglycemic episode. Incorrect morning insulin technique. This really wouldn't explain, this would cause like more glucose levels, if anything, right? If you administer insulin incorrectly. Right, long-acting insulin mismatch. He's not really taking any long-acting insulins. Early morning cortisol surge. Cortisol causes hyperglycemia, not hypoglycemia, so this does not make sense. Okay? Okay, so which of the following class of drugs should not be taken together with ketoconazole? Is this proton pump inhibitors, diuretics, biguanides, or beta blockers? Okay, the answer is proton pump inhibitors. So, as mentioned in the lecture, ketoconazole, it requires a highly acidic pH of the stomach to be absorbed efficiently, right? So if you are taking something to kind of decrease the acidity of the stomach, such as PPIs or antacids or any other drugs that you take for, let's say, gastroesophageal reflux or any other disease, this will decrease the efficacy of ketoconazole because it will not be absorbed efficiently. Okay, so if they, this is a very straightforward question that I put together very last minute, but if they ask, for example, a patient comes in, he takes medications for GERD or peptic ulcer or any other disease to decrease acidity of the patient, then you will always have to think about how ketoconazole is not efficiently absorbed in these conditions. Okay, next question. Please select the correct order of management of pheochromocytoma. I don't know why the numbers look like this. Okay, surgical resection of the tumor, salt loading the patient, administering phenoxybenzamine, and administering propranolol. Okay, here the answer is going to be, again, pause if you need to. The answer is going to be C. Okay, let's go through it. So surgical resection of the tumor, okay, ultimate curative treatment for pheochromocytoma is surgical resection. Salt loading the patient, sure. Administering phenoxybenzamine, which is an alpha blocker, and administering propranolol, which is a beta blocker. So pheochromocytoma, always remember, administer alpha before beta, right? A before B. So always you do phenoxybenzamine before propranolol, which is 3, then 4. So you start with 3, then 4. And before surgical resection of the tumor, you have to achieve these blockades, which is alpha and beta blockades, to ensure, appropriate surgical resection of the tumor. Then you salt load the patient, and then you surgically resect the tumor. And this is because when you resect the tumor, you can have sudden hypotension of the patient because of resection of this tumor. Okay, so you first have to salt load the patient to avoid any kind of morbidity associated with hypotension because of resection of pheochromocytoma. Okay, so first alpha blockade, secondly beta blockade, then salt loading the patient just before the surgery, and then surgical resection ultimately to remove pheochromocytoma. Okay, again, just quick review of pheochromocytoma. So what questions will I ask? Okay, what is the, what do you call it? What are the symptoms? Symptoms would be episodic headaches, palpitations, hypertension, feelings of impending doom, like episodic, keyword episodic. Okay, then how would you diagnose the patient? You would check for urine metanephrines, which include homovanillic acid, vinylmandelic acid, etc. And you will check for serum epinephrine, norepinephrine, and yeah. And then the surgical resection is pheochromocytoma. It originates from what cells? It originates from adrenal medulla. It originates from adrenal medulla, which comes from neural crest. And yep, just some few high-yield facts about free chromosomes. Okay, which of the following best describes the mechanism of action of clomiphene citrate? Okay, we reached REP363. Okay, the answer is C, clomiphene citrate. You should know that this is a medication used to induce ovulation, and it basically blocks the receptors, the estrogen receptors in the hypothalamus, which reduces the negative feedback of the estrogen to the hypothalamus. So the hypothalamus produces more FSH-LH to induce ovulation, right? So when is clomiphene administered? Extra question. Clomiphene is administered on days 2 to 5 of the menstrual cycle, and for how many days? It will be about 5 days continuously. And what are the side effects of clomiphene? Well, I hope you answered, because there are a lot of them. Okay, so side effects of clomiphene, think about postmenopausal type side effects, okay? Because it causes estrogen receptor blockade, not only in the hypothalamus, but also in the other areas, right? So if you have basically inhibition of the effects of estrogen, that is similarly to being in menopause, right? So this will cause hot flashes, headaches, mood swings, visual disturbances, breast tenderness, ovarian enlargement, everything that, not ovarian enlargement, but other than that, most of the things that happen in postmenopause, basically. Endometrial thinning, nausea, vomiting. So adverse effect of clomiphene citrate, always think of postmenopausal symptoms in general. Okay, multiple pregnancies, because when you have when you cause or when you induce ovulation, you might ovulate a lot of eggs at the same time, right? When artificially these things are done. So you always have to kind of keep these things in mind. Okay, moving on. A woman with anovulatory infertility is treated with human menopausal gonadotropins, or HMG, for ovulation induction. Which of the following is the most important complication to monitor this drug? Monitor for during this therapy? We just talked about it a while ago. So the answer is going to be ovarian hyperstimulation syndrome. Okay, so the drugs, any of the drugs which we use to induce ovulation, we always have to keep in mind that it can ovulate, but it can cause hyperstimulation of the ovaries, which means that it can cause maturation of more than one eggs at one time, right? And these can lead to what do you call it, multiple pregnancies, ovarian hyperstimulation, etc. So endometrial hyperplasia, it's okay. So I have a question. So why not endometrial hyperplasia? I think, yeah, why not other options, basically? Why not endometrial hyperplasia? First of all, because HMG, it kind of acts like, it kind of induces both FSH and LH. So this kind of mimics physiology. In normal physiology, we don't have endometrial hyperplasia because we have both estrogen and progesterone affecting the endometrium, right? So estrogen causes hyperplasia, not hyperplasia, it causes proliferation of the endometrium, and then progesterone comes and it just maintains it. It prevents from hyperproliferation or hyperplasia of the endometrium, right? So any drug that causes an increase in both estrogen and progesterone will cause it will not cause endometrial hyperplasia. However, we'll come to next questions about these things. However, any drug which causes increase in only estrogen, it will cause uncontrolled proliferation of the endometrium and thus increasing the risk of hyperplasia and cancer. So this is something that you have to keep in mind. Other than that, adrenal suppression, it's not really relevant in this case. And thyrotoxicosis, again, it's not really relevant to our case. Thyrotoxicosis is more to do with thyroid hormone supplementation. Adrenal, it's more with exogenous steroids and those things. Okay, so next question. 25-year-old woman presents with primary infertility. Her menstrual cycles are irregular, occurring every 40 to 60 days. Okay, she has signs of hirsutism and acne. BMI is 32. Serum FSH and LH are within normal range, but LH is slightly elevated relative to FSH. Okay, estradiol is normal. Prolactin, TSH are within normal limits. Pelvic ultrasound shows multiple peripheral follicles in both ovaries. What is the most likely WHO class? What is the answer? Pause if you need to. The answer is B, which is WHO class 2. Okay, why not the other options? Do I have a slide about this? Okay, no. So I'm just gonna say it. So there are 4 classes of WHO that WHO has determined for ovulation disorders, right? So WHO class 1, it is hypogonadotrophic hypogonadism, right? So this is basically to do with the hypothalamus and the pituitary, and anything that causes primary amenorrhea, right? So this will cause low FSH, low LH, and low estrogen. So everything will be low, right? So it's hypo. And for these patients, you give them a pulsatile GnRH or something to induce not only ovulation, but also hypothalamic release of other, of GnRH, no, not hypothalamic release, but pituitary release of FSH and LH, because the problem is with both the glands. Okay. Class 2 is eugonadotropic and ovulation. Okay. So this one is due to normal FSH and normal LH levels. However, you have, what do you call it? I just lost my train of thought. But it is basically when you have an ovulation, but not because of something above the ovaries, right? So above the ovaries, everything's fine. Your pituitary is fine, hypothalamus is fine, but your ovaries themselves are not producing enough hormones to cause ovulation or induce ovulation. And this is what we see in polycystic ovarian syndrome. If you could guess from the question, the patient presents with primary infertility, irregular menstrual cycles, signs of insulin resistance, which is hirsutism, acne, high BMI, serum FSH, LH. So all of these are signs of polycystic ovarian syndrome and insulin resistance, right? So again, they told us prolactin, TSH are within normal limits so that we can rule out pituitary adenomas, which can suppress the FSH LH production. Estradiol is also normal. Okay, so for PCOS, we have to keep in mind the LH levels, which is usually high, and this is a diagnostic of a PCOS. And pelvic ultrasound is also important. Pelvic ultrasound is actually diagnostic, but LH levels are also clinically high in PCOS. So you see multiple ovaries in PCOS and sorry, not multiple ovaries, multiple cysts in the ovary in PCOS, and yeah, that belongs to class 2. So how do you manage PCOS? You start off with lifestyle modifications, so decrease of any of the risk factors that the patient has. In our case, her BMI is high, so we would ask for, weight reduction, lifestyle modifications, diet, exercise, all of those. And then we can move on. If the patient also has diabetes or has signs of insulin resistance, then we can start with metformin as a first-line therapy. We can also induce ovulation through clomiphene citrate, as we took a few, just the previous question. Okay, or we can do other lines of therapy, but the first 3 treatment options are lifestyle modifications, metformin, and clomiphene citrate. Okay, class 3 is hypergonadotrophic hypogonadism, which is when you have increase in FSH, LH, and decrease in estrogen. Okay, then and class 4 is related to prolactinoma and how it suppresses FSH, LH, and all of that. It's not really that important. Remember, class 2 is PCOS, that's very high yield. And yeah, so that's why it's not the other options, it's class 2. All right. Which of the following is not a relative contraindication for clomiphene citrate? So here you have fibroids, ovarian cysts, chronic liver disease, and anovulation. This is a very, very easy. I just brought this just to shed light onto the contraindications of clomiphene citrate. So the answer obviously is going to be anovulation because it is one of the indications for clomiphene citrate. Fibroids, and what are the contraindications? Fibroids, which are very large, ovarian cysts, and chronic liver disease. Chronic liver disease, ovarian cysts, and fibroids are relative contraindications for clomiphene citrate. Okay, all right, next question. A 26-year-old woman asked her family physician for a hormonal contraceptive. She refused other methods of contraception. Past history showed disseminated intravascular coagulation, or DIC, that followed an abortion due to placental abruption. Which of the following would be the most appropriate hormonal contraceptive preparation for this woman? Okay, I'll give you a minute to think. Actually, you can pause the video. Okay, so the answer is going to be levonorgestrel. Okay, why is that? Why not other options? Okay, why not other options? Because All right, let's begin one by one. So the patient wants a method of contraception. However, she has a history of DIC, which is a thromboembolic event, right? Or a thrombotic event or coagulation-related events. Any of these kind of blood-related or blood clotting-related events will immediately be a contraindication for combined oral contraceptive pills or estrogen-only pills because estrogen increases the risk of thromboembolic events, right? So why not the other options? So the other options, levonorgestrel is here, but you also have estradiol here, which is contraindicated. Mestranol, norethindrone, these also have estrogen everywhere. Mifepristone, it's not really used as, what do you call it? As a contraceptive drug anymore. Mifepristone is more of an abortive therapy. Yeah, it causes uterine contractions and all of that, so it's not really relevant to our case. Okay, so what other conditions would you not use combined oral contraceptives in? Well, there are a lot of contraindications, right? Where you should not use combined oral contraceptives. So these include a lot of them. So there are 4 categories. We didn't have this in our lecture, I believe, but this is a very good summary. So category 1 is where you have no restrictions. So someone who is in her reproductive years. So beginning of menarche to less than 40 years. After 21 days of postpartum, post-abortion, endometriosis, iron deficiency anemia, all of these will have indications of using combined oral contraceptives or no contraindications, right? Then category 2 is where benefits outweigh risks. Okay, benefits outweigh risks mean you use it based on like a case-to-case basis, right? Then you have category 3, which is where risks outweigh the benefits. This is where we start to have the contraindications, where if you don't really have to use it, you're not going to prescribe it, right? So this is going to be cigarette smoking, postpartum, cholestatic jaundice, and less than 21 days postpartum, because this will increase the effects of venous thromboembolism. And the absolute contraindications are stroke, coronary disease, hypertension, thrombosis, breast cancer, suspect pregnancy. Obviously, you cannot use oral contraceptives in pregnancy. Okay, less than 21 days postpartum, and breastfeeding women who are less than 6 weeks in postpartum. Okay, so just to summarize, the category 4 is mostly related to coagulation and blood-related diseases, so stroke, coronary artery disease, hypertension, thrombosis, and all of these. And it's related to anything related to pregnancy. So pregnancy, postpartum, and breastfeeding. Postpartum, less than 21 days. Breastfeeding, less than 6 weeks. Okay? I hope that makes it easier. Okay, next question. So a 23-year-old woman at 42 weeks of gestation comes to the ER saying her water broke. Her Bishop score is 7. After administration of the appropriate drug, she now has 7 contractions in 10 minutes. What is the drug used and what is the next step? Okay, so the answer here is going to be D, which is oxytocin, and stop the drug immediately. Okay, so why oxytocin and why not prostaglandin? Here, we use oxytocin because her Bishop score is 7, and we know that anything more than 6 is going to be augmentation of labor, right? It's not going to be cervical ripening. For cervical ripening, we would use prostaglandin. However, for augmentation of labor, we would use oxytocin. And here, her Bishop score is 7. Her, what do you call it? Her amniotic membrane is broken, so there is rupture of membrane, and she has a Bishop score more than 6, which is why we will use oxytocin. And what do? You stop the drug immediately, because what is going on here? What is the side effect that we're having? The side effect we're having is tachysystole. Okay, how do you define tachysystole? Tachysystole is going to be more than 5 contractions in 10 minutes, measured over a period of 30 minutes. Okay, remember, 5, 10, 30. Okay, more than 5 contractions in 10 minutes, measured over a period of 30 minutes, and she's having 7 in 10. Okay, so here. Tachysystole is more than 5 over 10 over 30 minutes. Okay, so whenever you have oxytocin or prostaglandin and it causes tachysystole, you should be reducing or discontinuing the drug until tachysystole stops, regardless of fetal heart rhythm. Okay, all right. these are just some things that you kind of have to know. Okay. A 53-year-old woman, postmenopausal, is diagnosed with estrogen receptor positive, HER2 negative, invasive ductal carcinoma of the breast. She undergoes lumpectomy with clear margins and negative lymph nodes. What is the most appropriate adjuvant systemic therapy for her? Okay, so the answer is going to be C, which is anastrozole. 1 second. Okay, so the answer is going to be C, which is anastrozole. So she has estrogen receptor positive, HER2 negative, invasive ductal carcinoma. So for any patient who has estrogen receptor positive, regardless of their HER2 negative or positive status, you will give them aromatase inhibitors, especially if they're postmenopausal, and in an adjuvant setting. So this can be after surgery or after tamoxifen therapy, right? So as it is mentioned here, postmenopausal women with hormone receptor positive breast cancer should be offered an aromatase inhibitor either initially or after tamoxifen therapy. Okay, so I hope this is clear. And HER2 status should not affect the use or choice of the hormone therapy. Okay, next question. 55-year-old woman is diagnosed with breast cancer, undergoes breast-sparing mastectomy. So the tumor margin did not show any invasion, and sentinel axillary lymph node biopsy was negative for nodal metastasis. The tumor was estrogen receptor and progesterone receptor positive, but HER2 receptor negative. So, after discussion of management options, the patient is started on tamoxifen. While on this medication, she experiences hot flashes that come and go in waves and affect her sleep. Which of the following conditions is the patient also likely to experience? So here the answer is going to be C, which is endometrial hyperplasia, as we talked about this. So tamoxifen, what is the class of drug? It is a SERM, or selective estrogen receptor modulator, which means that it is an anti-estrogen in certain parts of the body, and it's an estrogen agonist in other parts of the body. So it is used here in what do you call it, estrogen receptor positive breast cancer, because it is an estrogen receptor antagonist in the breast. However, it is estrogen receptor positive in the endometrium. So this causes endometrial proliferation and hyperplasia, and has an increased risk of endometrial cancer. Can you tell me other risk factors for endometrial cancer? So those would be anything that increases the duration of estrogen that the endometrium experiences. So that would be early menarche, late menopause, nulliparity, combined oral contraceptive pills, or especially estrogen-only pills, greater effect definitely. Other than that, it would be smoking. It would be, what do you call it? And breast cancer therapy. Okay, I hope that makes sense. So adverse effects, again, it causes endometrial hyperplasia and cancer, which is an agonistic effect. So don't think that tamoxifen is an estrogen receptor antagonist. It is a modulator, which means that it is both agonist and antagonist depending on which tissue it's acting on. Okay? All right, other adverse effects would be vaginal discharge, amenorrhea, menstrual changes, and fluid retention. Okay, these are things that you just have to know. Okay, a 36-year-old woman with triple negative breast cancer is receiving neoadjuvant chemotherapy. She develops severe tingling and numbness in her hands and feet. Which agent is most likely responsible for her symptoms? So that is going to be paclitaxel. Tell me, what is the mechanism of action of paclitaxel? So the mechanism of action is, it's a taxane, right? It inhibits microtubules, or it inhibits the activity of microtubules. And what is the side effect here that we're talking about? We're talking about peripheral neuropathy. Okay, so it's an alkaloid or vinca alkaloid, and it targets tubulins, right? And it inhibits depolymerization of microtubules. Adverse effects, therefore, include vomiting, neuropathy, and myelosuppression. Okay, all right. It blocks the progression of mitosis and activation of mitotic checkpoint triggers, whatever. So anything that progresses or causes the cell cycle division and affects anything of that, it will always cause myelosuppression, because that's how cells divide. And if you don't let cells divide, you will have suppression of your myeloproliferative cells. Okay, reaching towards the end. A 58-year-old woman with hormone receptor positive breast cancer is started on anastrozole, which is, again, we said it's an aromatase inhibitor. 6 months later, she reports joint stiffness and a low trauma wrist fracture, which means that, you know, sometimes people are increasingly susceptible to wrist fractures or fractures in general, and that would cause a low trauma wrist fracture. Which additional therapy would most likely benefit her? So this is going to be B. So adding bisphosphonate, as she has a bony, what do you call it? Bone-related side effects, which is decreasing her bone density, and she's increasingly susceptible to fractures. Adding bisphosphonate would cause what do you call it? Relief of those symptoms. And we know bisphosphonate, it affects osteoclastic activity, so it increases bone density. Okay, so this is from the slides again. Bisphosphonates, in addition to local standard therapy, it causes improvement in bone density. Okay, so it causes improvement in bone density. However, you have to remember that the side effects of bisphosphonates are also related to the bone. So increase in bone density, you can think of it as like so much increase that you have pain in your bones. Okay, so much increase that you have necrosis of your bones or osteonecrosis of the jaw. Okay, and other, what do you call it? Side effects are esophagitis, ulcers, and kidney injury. Okay, all right. Then question 24. A 39-year-old obese woman was admitted to the hospital because of a severe pain in her right calf. Medication history included chronic bronchial asthma, currently treated with inhaled albuterol, and mild type 2 diabetes, currently treated with chlorpromamide and metformin. She had been taking combined oral contraceptive for 2 years, and physical examination shows this. Duplex ultrasonography confirmed the diagnosis of deep venous thrombosis, and which of the following drugs is most likely causing the patient's disorder? Again, should be easy now. We went through this. So the answer is going to be C, which is ethinyl estradiol. Ethinyl estradiol, or anything that causes estrogen, will increase the risk of venous thrombosis or any kind of thromboembolic or thrombotic conditions. All right, that's why category 4 as anyone with hypertension and anyone with any kind of increased susceptibility to clotting, we would avoid combined oral contraceptives. Okay, and the presentation that she is coming with here is severe pain in her right calf, which is a sign of deep venous thrombosis. So any kind of erythema, tenderness, what do you call it, increase in temperature of the calf, you always have to think about DVT. Okay, all right. Which of the following antibiotics is not teratogenic? So we have kanamycin, amoxicillin, tetracyclines, and fluoroquinolones. Very easy. The answer here is going to be, that's not right. What do you think the answer is? The answer is going to be amoxicillin. Okay, sorry for the mistake here. It's going to be B, amoxicillin, which is not teratogenic. Tetracycline, fluoroquinolones, kanamycin, or other aminoglycosides are all teratogenic, as we have here. So they're known to be teratogenic, should be avoided entirely during pregnancy, including streptomycin, kanamycin. These cause hearing loss. Tetracycline, which will cause which will affect the teeth, right? So I saw this mnemonic in first aid, which was tetracycline. Do with that as you will. So tetracycline will cause teeth malformation and long bones discoloration. Long bones malformation and teeth discoloration, and fluoroquinolones will affect development of cartilages. Okay, so fluoroquinolones, cartilages, tetracycline, teeth, and aminoglycosides would be hearing loss. Okay, there was a mnemonic for aminoglycoside as well. I just can't remember it right now. I can't remember it. You can refer to the book. And that brings me to the end of my session. Thank you so much for joining or watching the recording. And if you have any questions, again, feel free to reach out to me. My number and my email are attached to this PPT. I wish you all the best. I know Endo Repro is very, very cramped, especially Repro being way harder than Endo, and it's like pushed to the last few weeks. I hope my session made it a bit easier to absorb pharma. I highly recommend watching Dirty Medicine for all the videos that he has. He has diabetes and other medications as well. Yeah, other than that, I think since the time is so limited, it is better to stick to the slides and not to use a lot of external resources. However, if that is what you're used to, um, uh, feel free to go ahead. Obviously, you're in third year now. You probably know how to, you definitely know how to study by now. Okay, and that's it. Inshallah, all the best, you guys. The exam, all it's always like very fair, I would say, some about ENDREP. So don't worry about it too much. Try your best. Just one more exam, you'll be done with third year. Essentially, you'll graduate med school. So yeah, all the best, and thank you so much. And oh, also, there's this QR code. Please scan this QR code to tell me any feedback, anything I can improve. And that's it. Thank you for